So 14 now. So first of all, thank you to Dr. Rajesh, and thank you, Dr. Mohit, for giving the opportunity. And thank you all for the organizers. We always love to participate in the Eco Workshop. And like we have, Dr. Mohit and myself have conducted lots of workshops. And yeah, we're doing online teaching as well. Whenever I do workshops, I try to do, live talks, which are more interactive. Now we have gone to hybrid pattern, which works for many of us because it saves our time, and then we can focus more on hands-on training during the actual workshop. So this is pattern is also good, but like to get that feel of the interacting with the delegates is not there. So I wish, I mean, we can still try to be interactive. I'm sure many of you are probably already scanning or learning to scan or already, interested to uh, learn more about this or might have heard lots of videos. So you're aware of all the parameters. I'll just try to make all the like bring everything together and make sense out of it. Yeah, this is my favorite slide. I tend to play in many of my talks because uh, whenever I teach chalk, I like to talk about this slide. So, we've made a lot of progress in neutral management, hemodynamics, and whatever these advances have helped in decreasing the neutral mortality. But many babies do survive still with some neuro disability or with some chronic the organ damage. So sometimes the intact survival is a problem. And babies going into shock is one domain where either they die or they survive with some morbidity, which is what we can improve. And obviously, there's a lot of evidence coming up for managing these babies, a lot of randomized controlled trials. I cannot say a lot. Actually, the literature is still not great for neonatal shock because we recently published the shock guidelines for NNF and lots of meta-analysis. And, we also did grade analysis and come up with some guidelines and protocols, which are good guide for managing the babies with shock. So although we want to practice evidence-based medicine, but over the year, the art of medicine or physiological understanding is going down. So I think that's why my talk is always on focusing on the physiology rather uh, than the evidence. So So, like this art of medicine is going down and which is, and then now we have as Dr. Rajesh was just now was telling us, we have a technology now which gives lot of parameters. You're doing echo and multi-para monitors. Now, a lot of these NIRS, other cardiac output monitors are there, which is adding the confusion and we are throwing with lot of information. But sometimes this common logic, as Dr. Rajesh rightly mentioned, yeah, you need to get a feel of the patient. Okay, physiologically the baby is improving. Okay, baby is in the right direction. The numbers might be telling us a story differently, but if you look at the baby as a whole, you can still understand and apply your basic principle and get the baby out. Obviously, knowing this additional parameters do help. So let's see, whether next 30, 40 minutes or 45 minutes, whether we can, come up with some sort of guidance for managing the babies with shock with help of echo, because this is the echo workshop we are talking about. So we'll start off with the case scenario. So 26 week or 800 gram, 33 weeks, baby was in NICU for almost 6, 7 weeks, 1.3 kilo, very stable on high flow, fully fed stable, and then suddenly presented with lethargy, apneas, and increased oxygen requirement. And then baby developed poor perfusion and abdominal distension, which was mild. So what are the possibilities, anyone? I want, as I said, I would love to have interactive audience. So feel free to unmute yourself and talk. And so when this situation is there, what are the things you coming in the mind? Anyone? Okay, yeah, people are typing. Perfect. Okay. So either NEC or sepsis. sepsis with shock. Okay, great. So yeah, those are the thing. Now maybe it's little late for NEC, isn't it? Like 6, 7 weeks down the line, you don't get next. So late onset sepsis was high on the card. So basically, we intubated and ventilated, started a protocol, second line antibiotics. We gave one bolus, and cap refill was 3 seconds. Baby's peripheries were warm. Blood pressure was 46/32, which is like reasonable at this age for this corrected. And then we performed the echo, which showed a contractility was good, but output was high, and the cardiac feeling was good. So what does this mean again? High cardiac output. Just now Dr. Rajesh mentioned. Her, his associate, she keeps on measuring the outputs and cardiac output. Does it always tell you the story? So anyone, what do you mean by cardiac output of 560? Is it normal, high, low? Already I'm saying it's high. How high is it? So high. What could be the reason why it's high? Anyone think if is there a PD associated with it, or why is it high? Vasodilatation. Okay. Yes. So to meet the metabolic demands. Yes, correct. So all of you are thinking in the right direction. So to meet the metabolic demand, the body's first response is to uh, increase the cardiac output to compensate the metabolic demand. And there is early stages. There is a warm shock. So there's a vasodilatation happening. But heart function is normal. So your cardiac output has gone up. So it is telling me, and the contractility is good. So good function, but the cardiac output is high, which is telling me that baby is going into early warm shock. So inotropes were ordered. Now, you're in warm shock, you want a drug which will help with the vasodilatation. So you need a vasoconstrictor, good contractility, so you don't need something to an inotrope. So we started. What drugs? Anyone? What drug one should start? NORAD. Okay. Add adrenaline. Anyone else? Any takers for dopa? Dopamine. Yes. Vasopressin. Norepinephrine. Nobody for vasopressin. Yeah, so you all are right. Even adrenaline is not completely wrong, but here the contractility is good. So if you start low dose adrenaline, it may not be a very good vasoconstrictor. So probably norepinephrine, dopamine probably are good choice. So all of you are thinking in right direction. So we started norepi, saline bolus was given, and metabolic acidosis was there, increasing lactate. We gave hydrocortisone. And however, the baby rapidly deteriorated, hypotension and mottled, severe metabolic acidosis, and then subsequent echo, the cardiac output seems to have slightly decreased, and the heart function seems suboptimal. So epinephrine was added. You get into deep, sort of desperate situation. So combination of nor-epi plus epi was given. Baby already went into DIC, started bleeding, and then baby died. Unfortunately, this baby died, and we feel like we did everything despite all the effort. Baby died, and the cause was a multi-resistant E. coli. Just now again we discussed, sometimes we don't get a response to the antibiotics. We do everything, but if the bugs are resistant, if you don't have an antibiotics working or the right antibiotics working on the bug, he had a ESBL, which was a multi-resistant. So the antibiotics which was started didn't work. Baby very rapidly deteriorated. So despite doing everything, baby died. So, and you wonder what you could have done, what went wrong, why this baby died, and this baby was with us for 6, 7 weeks. What else we could have done? And that's where, I think sometimes taking help of the multipara monitor or early echo markers or predicting these babies, picking up these babies early does help. And some additional information definitely is useful. And so that brings you to the limitation of the clinical parameters. So many times what happens, nobody's intentions are wrong. Always, it is about the late pickup is often about the clinical acumen of the nurses, or even if you have a good clinical acumen, the limitation of the clinical science itself, which leads to delayed detection of the shock, and then baby end up, by the time you're diagnosed, baby is already decompensated. So you missed the bus already, and then you try to do everything whole night, you struggle, and then baby still don't pull through. So capillary time is often we like to watch, but has a limited accuracy predicting low cardiac output. So now I will next few slides, I will do talk about blood pressure, systolic, diastolic, but I will talk about cardiac output also, because what is more important is the perfusion. The whole focus of the hemodynamic assessment is to talk about the perfusion to the organs. So if you do capillary fill, even if it's normal, you still can have a low cardiac output, which will not be picked up. So capillary fill has its own limitation. Blood pressure, well, blood pressure can be normal initially. Like in this case, the BP was okay. Okay, average time gap between clinical versus echo features of shock. Good question. We'll come back to you. Uh, so uh, yes, I mean, echo also may not pick up. Early stages, even echo might miss. So it is a combination of clinical, echo, biochemical parameters, which actually gives you the hint. So not always one precedes other, but many times, yes, I have picked up sepsis based on echo because the cardiac output was suddenly high, no expected things, and and then we did the bloods and the baby came back as septic. So echo can sometimes precede, but not always. And I'm not here to sell echo. Yeah, do echoes. It's always the whole clinical picture along with echo, biochemical parameter, multipara. Baby always gives some subtle signs which we need to start interpreting, and that can help. So I was talking about BP can be normal, like in hemorrhagic shock or a cardiogenic shock. You might have a low cardiac output, but baby will vasoconstrict and the blood pressure might look normal, but because of the low cardiac output, baby might be in shock, leading to high lactate, high metabolic acidosis. And you will say, oh, the cap refill is normal, blood pressure looks normal, still why baby is acidotic? Or in this particular case, your BP might be normal because although there was a vasodilatation, so systemic vascular resistance has dropped, but the cardiac output was high. So baby was compensating, but baby was in septic shock, early septic shock. So the biochemical parameter derangement was there. And then echo, there were some signs. So blood pressure also does not tell the whole story. Cardiac output, systemic vascular resistance are also important. And then other parameters like urine output, lactate, pH, base excess, all blood gases, they are all late signs of decomposition. So when these are abnormal, your urine output is dropped to less than 1 ml, you've already missed the bus. You're already late. So clinical signs of compromised perfusions are often late, and the sensitivity is only 55 to 70%. So 30-40% of the time you will miss that baby is going into shock. And by the time it present, baby is already in uncompensated or irreversible shock. So that's why sometimes early prediction is good. Having good nurses, good RMOs staying on site, predicting the baby early. Sometimes parents tell you, okay, my baby is not looking quite right, something is not good. That helps actually to predict and pick up these babies early. And then early intervention will help to prevent right time starting the first dose of antibiotics, giving the first dose, and starting all relevant inotropes with ongoing monitoring does help to survive these babies. Now, just a bit of a background about the shock, what exactly the shock means. So in the normal body, I hope no questions so far. So in a normal body, your blood pressure, it's not only about the blood pressure, but it's about the perfusion and the oxygen delivery, which is important. So normally, your metabolic homeostasis is maintained uh, at the level of cellular metabolism by two things. There is a fine balance between amount of oxygen delivered and amount of oxygen consumed. Now, in cases of diseases, sepsis or any other disease states, there's an increased work of breathing, and that's why the basal metabolism will increase. Okay, and that's why the oxygen consumption will go up, and the oxygen delivery also then needs to compensate. So in the early stages, the oxygen delivery will get compensated, and it needs to compensate. Otherwise, baby will go into shock. So if there is a disparity between oxygen delivery and oxygen consumption, you will get shock. So demand supply. So you the oxygen delivery is determined by your hemoglobin levels, uh, which is which will be low in anemia or hemorrhages. The saturations of the blood, oxygen saturation, which will be determined dependent on the lung disease. So you might be going into shock, but you might also have a lung disease. You might have a meconium aspiration and with sepsis, and that's the beauty in the newborn period, that they don't come in isolation. They come as a mixed picture. So you might have a MAS with lung disease, with septic shock, with PPHN. So you have a combination, and then you don't know which is what. So that's why we don't tell about one drug choice for one particular type of shock. It is about what exactly going on in the baby. Then you have to treat that underlying thing. So, say if hemoglobin is low because it could be hypovolemic shock also, baby who has bled, and then there is anemia and has got meconium aspiration, so the oxygen saturations are low, and this baby could be a late preterm, which could be having a PDL, so shunts could be there. So that all determines the oxygen delivery. Now, the most other thing which we keep talking about is the cardiac output. So cardiac output will determine your oxygen delivery. And what is dependent on the cardiac output is dependent on what are the factors on which cardiac output is dependent? Anyone can type in the chat box. What determines the cardiac output? Anyone? So stroke volume and heart rate. Correct. So cardiac output is determined in the heart rate, and the stroke volume will be dependent on the preload. How much is the blood coming into the heart? And then what is the heart after load? So cardiac output is, yes, SV times heart rate. And also to give a good stroke volume, you need to have a good contractility. So these are the factors which will determine. And then comes the interaction between your SVR and BP. So all these things might be okay, but then blood pressure still might drop if the SVR is low because of the sepsis, systemic SIRS, all those things. Okay, so all this interaction will play a role. So that brings to the concept of different types of shock. So what are the three we already mentioned, but what are the three important things which are important, which are very crucial to maintain the hemodynamic stability? What are the three factors which are important? Anyone can type. So to have an adequate perfusion, we just discussed the slide. To have enough blood or oxygen reaching the perfusion or reaching the cell at the organ level, what are the things which are required? Cardiac output and CaO2. Okay. Now we are talking about hemodynamic parameters. So your capillary oxygen levels or all those things will be dissolved forms. Yes, it is important. But for hemodynamic stability, what are the things? So first is intravascular volume or preload. You need to have an adequate volume for heart to pump. Okay, that's your preload. So preload and afterload. Correct, Dr. Ashadur. You all know, I don't think you need me, right, to teach. So intravascular volume is required. So that is your preload. And if you have a hypovolemic shock, placental abruption, or sepsis, where there's third spacing happening, your intravascular volume might be low. You will go into shock. Next thing was you might have adequate volume, but your heart needs to function appropriately. So as we discussed in the previous slide, so you might have a poor heart rate or a bradycardia or a congenital heart block, and that will hamper your cardiac output. Or you might have a myocardial contraction effect because of the HIE or hypoxia or any intrinsic defect in the heart. So excuse me. So all the things will depress the heart, like cardiomyopathies, HIE, metabolic conditions will cause decreased contractility of the heart. And congenital heart blocks will cause decreased heart rate. So this is the second component which is important. And the third component is vasoactivity. So vasoactivity is your SVR. So in sepsis, NEC, or systemic inflammatory response, this vasoactivity will decrease. Can we measure by any device? So generally, SVR is difficult to measure. It can be calculated with help of blood pressure. But there are devices like non-invasive cardiac output monitor, which I have not covered actually. There are a few slides about it, but that device can tell you about the SVR also. So now that brings us to the focus of the talk. I spent so much time in the background, but this is very important because echo indices will be yeah, icon. You're right, Chinmay. So if have you used icon? So if you have used icon, the icon device will tell you icon or Nikon. There are like this non-invasive cardiac output monitors. We had in our previous unit, we had 20 of those. So we used to monitor this for all the babies and for every bed. And so there are devices which will constantly tell you the uh, SVR or systemic vascular resistance, but it's a calculated value based on the systolic diastolic blood pressure. So all the echo indices now of the shock are basically to determine all this. So you need to determine the intravascular value. So you might, but to do how's the IVC feeling, IVC contractility, eyeballing the cardiac feeling. Then there are parameters to measure the contractility. So ejection fraction, fraction shortening, obviously heart rate you already measure. And then also the cardiac outputs you want to measure. So LVO, RVO, all those things. And in the contractility, also there's diastolic function parameters are there, which might help you to determine if there's a cardiac dysfunction. And vasoactivity or SVR will be the calculated value based on the blood pressure. So if you know all these parameters, you know what is going wrong and what type of shock it is. And that tells you how to treat also. So these are the common types of shocks you see in the newborn period. So hypovolemia generally causes dehydration is very less common going into shock, but as again, which is common more in pediatric population, but in newborn, out of time it is placental bleed, hemorrhage, abruption, twin-to-twin transfusion, blood trauma, subgaleal hematomas, all those things can lead to hypovolemic shock. Then cardiogenic shock, immature myocardial contractility, like in premature baby. PDA can also have a cardiogenic shock, secondary to maturity and all other things. Pulmonary hypertension also might have a RV dysfunction. But more common cardiogenic shocks in human is hypoxia, asphyxia, or sometimes metabolic conditions affecting the heart. And then vasoregulatory or distributary shock, which is common in sepsis or NEC. So this is in the nutshell. So if you know, we already know by the history what kind of a shock it could be, then we probably would assess this on the echo as well. Now, before we understand the cardiac output and measure the cardiac output, we need to understand that interpretation of the cardiac output is not very straightforward as it's in the pediatric population. So we know that the cardiac output, the LVO from the left side of the heart will go to the systemic circulation and come back. So if your LVO will often represent a good marker to tell you what is going on at the systemic level. And RVO will be good marker to tell you what's going on at the pulmonary level. And you can calculate this QPQS mismatch. They know what is the amount of blood going to the pulmonary versus systemic. So all this is very good to talk about in pediatric population. But in newborn, the problem is newborns are often in the transitional circulation. So they have shunts. So the blood returning from the RA, which is the systemic blood flow, which brings all the blood back to the RA and it goes to RV and then it got ejected into the pulmonary artery. But the RA is also contributed by blood coming from the LA because of the PFO. So RA doesn't only have systemic blood flow, but also have a atrial shunt blood. So RVO is your systemic blood flow plus arterial shunt. And I'll show you how we measure that. Now, LVO is the blood going to the systemic circulation and is contributed from the LA, and the main contribution for that is pulmonary blood flow. However, some blood goes into the LA and then some blood which get ejected from the LV can get shunted across the PDA, and that goes to the lungs and bring back to the left side of the heart. So LVO in presence of PDA and without PDA is different. So you might have a good LVO, but you still might be underperfused in presence of PDA because there is a shunting going on. So that's why when you are looking at one number, you have to look at shunt levels as well. And that's why when baby with PDA, they look like they're in shock, they're in metabolic acidosis because this shunt is taking the blood away from the heart. So LVO is effect of pulmonary blood flow, but also ductal shunt, which is bringing the blood back to the LA. So that's why in PDA, the LVO will go up, it will significantly increase. So high LVO could be because of the PDA, because there's a constant blood shunting across the PDA. And that's why we say that RVO might be a good surrogate of the systemic blood flow because it is mildly contributed by atrial shunt, but mainly by the systemic blood flow, both IVC and SVC. So it will be a good contributor for the systemic blood flow. And LVO is often the measurement of the pulmonary blood flow because often PDA, in presence of PDA, the major determinant for LVO might be PDA, apart from pulmonary blood flow. So that's why the interpretation is slightly difficult. And this is just the systemic flow, the proportion, how much goes to where, and your RBO, same thing again. RBO is systemic blood flow plus left intraarterial shunt flow, so PFO. LVO is systemic blood flow plus ductal shunt flow. And then you can also have a flow in the aorta, so distal aorta, which is systemic blood flow minus the blood going into the upper body flow. And then the SVC flow, which is the systemic blood flow minus the lower body flow. So again, I don't want to confuse you, but this is just an understanding that suppose there are parameters to measure the descending aorta flow. There is a way we measure the SVC flow. So SVC flow will mainly give you the upper body flow. But the importance of SVC flow is it's independent of the shunt volume. So, and it will give you the important information of the most vital organ in the body, which is brain. So SVC flow also can be done as a surrogate for a shock. If your SVC flows are low, you might be in a bad shape. The baby might be in a critical stage because often the body will compensate to have an adequate flow to the brain. But even that is impaired, that means there could be shock going on. So that's how we correlate the systemic flows. So that brings to the different parameters of indices. And then I'll take you to different other parameters about blood pressures and other indices of the shock. So now I'll take you to, we'll start from the heart and then we'll go to preload and afterload. Okay. So first thing in the shock assessment is about measuring the cardiac outputs because that is our sort of interest ultimately. If your cardiac output is poor, then you are in trouble. Okay, but as I mentioned, that you have to interpret with presence of shunt. So how do you measure left ventricle output? So in a parasternal long axis view, so I hope the views are covered. So I'll not have to go back to the views, right? Everyone now has learned the views, basic views. At least you're aware about the parasternal long axis views and everything. So I'll not have to go over this again. So your parasternal long axis view, you have So this is your LV, okay, and that's your aorta coming out, and you can zoom. And this will give to like this picture. So you have two hinge points, and you can measure the LVOT diameter, which is like 6 millimeter in this way. So to calculate any cardiac output, you need two parameters. One is the diameter of that vessel, for which you're going to calculate the output. So it could be aortic or pulmonary, and then amount of blood going across that valve, which is calculated by pulse wave Doppler across the aortic valve. So what view is this? Anyone? Please type. What view? What view is this? Nobody is committing to the views. Yes, apical fifth chamber. Correct. So it's a 5-chamber view. So you have opened the LVOT, and then you put a Doppler across the LVOT, which will give you this kind of a view, which is the pulse wave Doppler. So this is the direction of the Doppler wave. So you will get this kind of a waveform. And now what we need to do is pick up the best one which is available, because you can always underestimate. You can never overestimate a VTI or the stroke volume. So I suppose I chose this one. What you have to do is you have to select LVO VTI and then go and trace like that. And that will give you this number, LVOT VTI, which is 18.9, which is pretty good. Okay. So this area under the curve calculates your VTI or velocity time integral. So it's the amount of sort of area under curve will tell you exactly what is the amount of blood injecting in each stroke volume. And then these two parameters will help you to calculate the cardiac output. So formula for cardiac output. So we got two things now, VTI on the pulse wave Doppler. So first you can calculate the stroke volume, which is VTI times the pi r square, or pi times aortic diameter square divided by 4, right? So area is pi r square. You multiply that by VTI. So if you're using diameter, then you have to divide by 2. So square it and divide by 4. But if you have a radius directly, if you have a diameter calculated, you divide by 2 and make a radius. And then you can just do pi and r square. And then multiply by the VTI, which will give you the stroke volume. And then you multiply stroke volume and heart rate. That will give you cardiac output. But important is cardiac index, which is the mLs per kg per minute. So you have to divide this by your weight per kg. So that's your LVO. Any questions on the LVO? Yeah, 5-chamber apical. Right. So I think everyone understood LVO. Now, LVO has been validated compared to echocardiography and phase contrast MRI. And maybe there's a bias of about 10 mLs per kilo per minute, which is not very bad clinically. If your cardiac output is 200 and actual on an MRI is 220 or 210, it's not going to really make a much difference in my management. So, yeah, so LVO has been validated. And I think I have got slides talking about low LVO, high LVO. But can somebody tell me where LVO will be high? Anyone can type? I think I've got the slides coming, but high LVO, warm shock, yeah, and PDA. Correct. Warm shock and PDA will have a very high LVO. And low LVO, when will be the cardiac output will be low? Decompensated shock. Okay. So we learned, right? What will determine the LVO? Preload is less, correct. So if you have a hypovolemia, your preload is less. Or cardiogenic shock, correct. Or obstructive and lower. Yes, Gumala, Dr. Gumala is and cardiogenic, correct. So either your contractility is less, that's why the ejection is less. So cardiogenic will have a low LVO. And if your preload is less, hypovolemic shock will have a low LVO. We will go through those images, but good, your understanding. Now RVO, so it's a RVO, you need a pulmonary short axis view, pulmonary, long axis view. You can do it in both short axis and long axis, but in the plaques view, right ventricular outflow. So this is the RVO, this is RV, and then going into RVO, and this is the pulmonary valve, and you can do measurements taken a caliper across the hinge point. So you just measure like this, and you get a pulmonary diameter, and then you also do the same thing as you did for aorta. So this is the pulmonary, and then you get the this thing pulmonary. You get the pulse wave Doppler across the pulmonary valve, and then you get again this kind of a waveforms where you can measure the area under curve, and you will get a pulmonary VTI, which is velocity time integral. Like here it is 7.3. Okay, so pulmonary VTI, and then again same formula you can apply. Pulse wave Doppler. So VTI times pi r square, which will be your stroke volume. And then you multiply that by heart rate, which will give you cardiac output. And cardiac index will be divided by weight. So stroke volume times heart rate divided by birth weight or current weight is the formula for the RVO. I hope it's clear. It's very similar to the LVO. So see just an example here. It's pulmonary artery, two babies. It's very low LVO here, about 0.2 meter per second. So there's one way of even eyeballing, if you don't want to calculate, is just to look at the VTI. So normally it's like this, up to 0.5 or some 0.6. But if it's low, then probably you know that you are in a cardiac dysfunction. So this is how RVO can be interpreted as well. Or suppose initially, there's a pulmonary hypertension. Your RVO was good initially, but later on your RVO has dropped. And along with that, maybe your TAPC, which is your tricuspid annular plane systolic excursion, is also dropped. Then it will tell you that probably there is a decrease in the function. So that's how you interpret. Okay, with serial measurement. Okay, the function is deteriorating, so your cardiac output, even the right ventricular output, is decreasing. There is a possibility of dysfunction, so you treat accordingly. Then you support the heart with epinephrine or milrinone like that. So yeah, we already discussed. So this is how the LPO RVO is calculated. Okay, I'll skip this. Now next factor is preload, and no, still one more thing remaining is the contractility. So we calculated the cardiac output. Then comes the cardiac chamber dimensions and also the ejection fraction and fraction shortening. So when you're suspecting cardiac dysfunction or cardiogenic shock or HIE, then you have to, after LVO, you go and check the uh, fraction shortening or ejection fraction. So how it is calculated? Uh, so basically, there are few ways which you can do it. The commonest one is the parasternal long axis view. I think the slide one here is one slide is missing, which is Black's view. So I'll just use this slide. So if you have this view, which is your parasternal long axis view, what you do is basically In this particular view, you have to focus on left ventricle. So this is septum. This is wall of the left ventricle. This is little bit of a margin. And you draw a line like this. So basically you have to put an M mode. When you put an M mode across the valves just distal to the mitral wall, then you will get this picture which I had shown like this. Uh, this particular view is done in the short axis view, so your heart is looking differently. So same thing can be done in a short axis view. Just distal to the mitral leaflet, you can cut vertically, and then you get this kind of a wavy picture. So here you're basically cutting the heart at the level of RV and then interventricular septum. So this IVSS or IVSD is interventricular septum in diastole. How do you know that? In diastole, this diameter will be widest, and in systole, this will be narrowest. Okay. So systole, these two valves come closer. So you will have a less diameter, and in diastole, it will be more diameter. So when you're calculating ejection fraction and fraction shortening, the machine will automatically calculate it for you when you do these measurements. And generally, it's about 50 to 60 or 65. And then if it is below 50 or below 40 or even if below 30, that's really telling you that there is a significant cardiac dysfunction. So measuring these diameters, internal diameter, this is the internal diameter of ventricle in systole, internal diameter in, sorry, this is in systole and this is in diastole. So you compare the systolic and diastolic diameter. So diastolic diameters are wider and systolic diameter are narrower. So you compare the systolic versus diastolic diameter, and that will give you your parameters of ejection fraction and fraction shortening. So normally, your ejection fraction will be around 50 to 70. If below that, probably you are starting to see there is some degree of cardiac dysfunction. Fraction shortening is also around 25 to 45%. And yeah, if there is a decreased function, these parameters will get affected. And any questions on this so far? Let me grab a water. Just give me 1 minute. The exact how you do this technique and all, those we will cover in the workshop. This is the theory aspect of it. So we are just covering the concepts and theory behind this. All the doubts related to how we actually acquire it, where do you put the marker and all those things we can cover in the workshop. So LVO, RVO, ejection fraction, fraction shortening. So decreased fraction or fraction shortening, ejection fraction will be in the cardiogenic shock. So all the condition affecting the cardiac contractility like HIE, metabolic disease, or even acidosis severe causing decreased function, or PPHN causing decreased right ventricular function, all this will cause decrease in the ejection fraction, fraction shortening. Now, there are other parameters which we will show you. Okay, this is the descending aorta flow. I think this is, we don't commonly cover this. This is more for a sort of advanced classes, and we don't routinely do. Similar to LVO, you can do a descending aortic flow. So basically just the VTI is calculated in the descending aorta, and descending aorta measurement is done, and then same formula can be applied for a descending aorta flow. So this is where, so you get the subcostal view with the aortic diameter, and then you get this is the aorta, arch of the aorta, descending aorta, and you can put a Doppler across like this, and you get a VTI. You measure this Doppler area under curve, and you can get a descending outer flow. So again, this is something not very routinely used, so I will not go cover that. So just going back to the cardiac output, RVO, LVO, these are the ranges. So normally, uh, around 150 to 350 is considered as normal. As you can see, in preterm it's slightly low, and day 1, day 2, and then picked up by day 5 to day 7. In term, generally it's about 250 to 350 sort of throughout, and baby, because these babies transition very fast, so the cardiac output generally is around that. RVO, LVO also around 200, so it goes like 240, 260 to 400 for preterm. So in preterm, it's they often start with low cardiac output, and slowly it goes up. And term babies, LVO is around again 200 to 300. SVC flow I'll cover in the coming slide, but SVC flows in preterm is around 60 to 80. And then it can increase up to 90 also, and term babies around 70 to 90. So, and as I was mentioning earlier, that SVC flow is a mainly tells you the flow from the upper part of the body, but it's a good surrogate of the systemic perfusion, and it is independent of the shunts. So it is still important to do that. Just some scenarios I had put it. A baby with lethargy, poor feeding, shock, and severe acidosis, and this LVO is like very low, and fracture shortening of only 18%. So see, this is the baby here, VTA is very low. So the cause was viral myocarditis. Okay, this baby had a viral myocarditis. So that's why your ejection fraction was low, cardiac output was low. Now, one more example of decreased RVO. So this was a 23 weeker, 500 grammer, maternal choreo, very smooth course first 4-5 dose. And then day 5 of life, develops some fungal sepsis and lung disease were worsened. And there was increased FiO2 and PPH and also on the echo. And we did advise not to close the ductus because baby has developed pulmonary hypertension. But the next day, the rounds baby developed more acidosis. So clinician decided to treat the ductus. He thought maybe, it's a shock. And without repeating an echo, the ductus treatment was started. And within 6-7 hours, baby completely went into shock and deteriorated. And this was the echo. So anyone can comment what did the echo look like? Yeah, interventricular septum D-shaped. So RA-RV looks very dilated. I agree. RV looks, and especially the RV looks so massively dilated. This whole thing is RV, and the LV looks very low. Even here, this whole thing is RV, and this is the septum is here, and LV is small here. So because the ductus got closed and baby had a severe pulmonary hypertension, the RV failed, and the RV output was very low. So decrease RV output and decrease RV function because of the pulmonary hypertension. So that made this baby, we lost this baby, unfortunately. But this is again where the role of POCUS is, we did mention that okay, we do not need to start, and then reversing this was difficult. So these are the cases we share because when you put the probe and like, oh wow, this baby is like really collapsing now. So you need to help. So we did start epinephrine followed by milrinone, but this baby did not give time. So sometimes this echo-based management do help. Yeah, this was the cardiac output. You can see VTI was only 2.2. So normally the VTI is around 8 to 10. This was very, very low. So very low VTI and very poor TAPSE. So TAPSE, there are slides for TAPSE, but I'll just talk briefly here. So TAPSE is a marker of systolic ventricular function. I think we have a functional assessment class separately covered. That's why I did not cover many parameters, but
He was covered by Dr. Tushar yesterday.
yeah, it was right. Yeah, that's why I read. So TAPSE and all those things were covered, but basically it's tricuspid annular plane systolic excursion. So how this tricuspid valve moves in a vertical plane, that tells you the contractility. So as you can see, normally the TAPSE looks like this, but here it was almost sleeping, very flat. So TAPSE was only 0.2. Normally it is 0.6, 0.4 to 0.6 in a very preterm like 550 grammar. But this baby had a significant poor right ventricle function, systolic function, and poor right ventricular output. So this was a kind of a cardiogenic shock secondary to PPHN after ductus was closed in a premature baby. So because premature babies have intrinsic myocardial dysfunction because they have premature myocardium, contractility is less, so they already are premature, so they will have some issues. Now PPHN and all parameters I'll skip because we have a separate class on PPHN, but PPHN can present with shock and left-sided preload issue and hypotension because of the suprasystemic pulmonary pressures, which causes less blood going to the lungs, less blood coming to the left side of the heart. So baby can go into the shock, and the PPHN parameters can be uh, assessed. And LVO increase, I think we already covered in the earlier lecture that sepsis can have a LVO increase, but in PDA, again PDA parameters I'm not covering. There's a separate shock topic, but basically whenever there's a ductal flow left to right, there's increased pulmonary flow, which will cause increased preload to the left side of the heart, and that will cause LA and LV dilatation, which might result in LV increased pulmonary venous pressure. But basically, babies with long-standing PDA will have a high LVO, 400, 500, even 600 ml per kilo per minute. So these are some of the examples of decrease, increase LVO, decrease, increase RVO, and that's how we interpret. Yeah, another increase LVO. Yeah, this was again sepsis, high LVO. Yeah, so HI and myocardial dysfunctions and all. So SVC flow, I'll quickly just go through it. So mainly in preterm babies, SVC flows will be useful. For babies who are with PDA and shock, acidosis, or even sepsis, there you can do SVC flow and look at the cardiac output as it is independent of the transitional circulation. But it only represents the portion of the total venous return and only reflective of the upper body flow, but it tells you the circulation to the brain. So it is still important. And usually it is about 30 to 50% of the total systemic blood flow. So it will just tell you the 50% of the story, but it is still good to do. And for that, you need to do SVC flow diameter in the left parasternal view, where you have a view where you have this SVC going entering the RA. And again, I think in the workshop we'll demonstrate. And then you put a M mode like this across, and you'll get a picture like this. So you get a diameter of the SVC. You might take 2 or 3 measurements, so minimum, maximum, and then average it, and that will give you the SVC diameter. And then you have a subcostal view, SVC flow view, either in the bicable view. There are two views where the SVC, IVC is seen, or in the atrial view. So this is the right atrium. There is a left atrium, and then you slightly angle up. This is the SVC. Red color is the SVC, and then you put a Doppler across, which will give you the parameters like this. Sometimes there's a little bit of reversal of flow. Ideally, you should take 3 and then average divide by 3. So as you can see, they are all variable. SVC flow will be variable, not be like accurate loops like we saw in the LVO RVO. So you have to take 3 and divide by 3, and you will get a SVC VTI. And again, same formula can be applied. Stroke volume. So you have a diameter SVC and you have a VTI. You multiply VTI by the diameter by the pi r square, and then multiply by the heart rate divided by the birth weight will give you the SVC flow. So I think same way you can calculate the SVC flow as well. And there are studies looking at SVC flow. Less than 30 is considered as abnormal. And there are a lot of data, especially from Australia, for babies less than 30 weeks, which can talk about the SVC flow. So cutoff is considered as, so you can see again a healthy preterm also, that the SVC flow initially is low. So go to 30, 34, 40, 46, and then it will keep on increasing at 5, 10, 20, 24 hours and 48 hours. But by second day, if the SVC flow remains below 40 and especially below 30, it's a matter of concern. Okay. So it is really correlated with adverse short-term outcomes and long-term outcome as well. And often babies with low SVC flow will have a poor perfusion in the kidney. So oliguria, hyperkalemia, ROP, NEC, all those risk outcomes are correlated. And babies with PD and all, they can have a more additional issues. Now, one thing, a few other things I will like to cover here, along with cardiogenic shock. Can you please show how to take SVC diameter once? So, I think we will have to demonstrate this in the workshop. So how you put it, basically left parasternal view. Sorry, somebody has asked the question, so I'll just quickly go back. So this is the view. So left parasternal, you can get it from here also, but often I try to do it from the left parasternal view with notch facing up, 12 o'clock, and then you look towards right, and you get you're basically looking towards the SVC entering the right atrium on this side. So you're looking from left side towards the SVC, then you get this kind of a view where SVC is entering into the RA. And then you want to do the M mode, which is in this vertical cut here. And then you get this view. And then you can measure the diameter. So more we will demonstrate in the actual workshop. This is just a prerequisite. So I hope Ashadur Zamal. Okay, you're so wherever you have a decreased contractility, always rule out the pericardial effusion. So these are some of the views for the pericardial effusions. You need to do a short axis, parasternal short axis view is the best view to detect the this thing, pericardial effusion. So this is the view where this is a parasternal short axis, and you have a, because that is where the tip of the apex of the heart is there, the fluid will start collecting and going up. So in short axis, you can see it's best. But as you can see, where it increases, even in the parasternal long, in the four chamber view, yes, like here, you can see a very nice, this is the heart margin, and this whole thing is the fluid. Okay, so this whole thing is fluid. Again, here, parasternal long axis view, this is LVOT, septum, this is septum, and this whole thing is a fluid. So this pocket of fluid, which is seen, is your pericardial effusion. So always when you have a depressed heart, decreased function, go back and also check the, and cardiac output is low, always also check the pericardial effusion. And I think this is okay. So some additional things. So there is also advanced modalities of assessing the function, especially in the shock patient and cardiogenic shock. You can do a apical 4-chamber like this, focusing on the LV, and a 5-chamber like this. You know the pointers and all already. So sort of 3 o'clock, 4 o'clock. And then you also can do something called as 3-chamber view, which is actually looks like an apical a parasternal long axis view at the apex. So this is called as 3-chamber view. Okay. So it's a LVOT seen in this view. And there is something called as uh, 2-chamber view. So see, these are the 3-chamber view and 2-chamber view. These are the additional views. Now, normally we don't do this, but if you want to do, so you can see how they are rotated. Basically, 4 o'clock, 5 o'clock, 6 o'clock, 6 o'clock. So basically, 3 o'clock is 4-chamber, 4 o'clock is 5-chamber, and then you get 2-chamber, which is at 6 o'clock, and then you go further anti-clockwise, and you get this view, 3-chamber view. So when you have 4-chamber view, 5-chamber view, 3-chamber view, and 2-chamber view, you can do something like this, which is called as speckle tracking. So there is a software which can apply speckles of the heart like this. So I've tracked all the chambers, and I can see that this will tell us if the segmental heart is contracting nicely or not. And if there is a dysfunction in any particular area, especially posterior areas in the HI, you might see the different color. Like here, you see this is little getting bluish. A nice red color means good contractility, and then there are some numbers which are displayed. So poor contractility will have a poor display of number, and then this all numbers will get into a wheel. Again, I have not put a report just to avoid confusion, but basically all these segmental can be combined into like a bullseye, and all the numbers are displayed, and that will give you a global cardiac dysfunction or not. So it will tell you which segments of the heart are moving, either whether the septum is moving less, lateral wall is moving less, posterior wall is moving less. So idea of doing these different views, 2 chamber, 3 chamber, 4 chamber, 5 chamber, is to look at the heart in different direction, in all the directions, and then put the speckle tracking. And they this give you a something called as strain rate, and there are some parameters which are calculated, and that tell you if there is a dysfunction. But again, this is a basic workshop, so we'll not be going into much detail. But these are the things which are available. So whenever you have a cardiac dysfunction, we tend to do the speckle tracking as well as a baseline, because if it's worsening or improvement, subtle changes can be seen in the speckle tracking. Now, one thing which I had not demonstrated earlier is, so we spoke about fractional shortening and ejection fraction, but suppose you're not able to, there is another way of doing this. There are advantages of one technique over another, but there is something called a Simpson's biplane method for ejection fraction. So this is where you are comparing the area, as you saw here in this particular view. So see here, you basically focus and freeze the left ventricular area, and then this is in the this is the in the diastole, so your valves are open, and then you measure the area like that, and then you change the focus. Now see, this valve is closed, so this is smaller diameter, which is the systole. So you want to do the area measurement like that. So you take the probe and track, and then you get a left ventricular internal diameter in systole. So this is in diastole. So this is in diastole, larger diameter, and this is in systole, smaller diameter. And when you compare this with this formula, LVED minus LV, so diastolic minus systolic divided by diastolic volumes, you get a ejection fraction. So this is called as Simpson's biplane method, and this is supposed to be more accurate if it's done in a correct technique. So ideally, in a patient with cardiogenic shock, you do both M mode for ejection fraction shortening, and also Simpson's biplane method. I hope it's clear. So Simpson's biplane can be done in a 2 chamber view also, or in a 4 chamber view. So this is 4 chamber diastolic versus systolic, and this is 2 chamber versus diastolic versus systolic, and same formula can be applied. And the numbers are same. Normally, the ejection fraction is around 50 to 70. If it's below 50, there's mild dysfunction. Below 40, moderate, and below 30 is probably severe dysfunction. So, Dr. Mohit, I've got another half talk left. It's 1 hour
No,
already.
it's
I think we should stop.
yeah, yes.
It's,
Actually, no,
we covered, I think, we covered basically what we covered. Uh,
yeah. So, but actually, this is only for the indices, so that will be fine.
that should be fine.
Basically, I would request everyone to concentrate on four things: eyeballing, FS, EF. These are the three things, and LVO.
LVO,
These are
RVO.
the four things.
I think.
Yeah. So
And
these are the four or five things.
Kiran, you can continue if you want for another 7 to 10 minutes. Till
Sir, it will
8:20.
be actually, it will be confusing for this thing,
Yeah,
because
yeah.
those things will
Okay.
be more advanced, and we want to stick to 4 or 5 basic things, so that this is what we would also do in hands-on session.
Yeah.
So that's why I think so. This is more than enough to digest,
Yeah, I
basically.
think there's a lot of information.
Mm.
So one thing Yeah, maybe I'll just show you one few things. Maybe go back and read our shock guidelines. Dr. Mohit and myself were part of the shock guidelines group, and we have already published the guidelines on shock. Although that doesn't talk much about the indices, which we will talk more in detail in the echo workshop. But basically, go through the specific things about definitions of shock. That less than 32 weeks. There are these German neutral network guidelines which talk about how do you define hypotension, and it's not always the mean equal to gestation. And so go back, and follow the Zubro's normogram for babies more than 37 week. And whenever we have a shock, as I was saying in the very first few slides, that it's always the echo, it is always the clinical blood pressure followed by another clinical criteria, is like at least one of them, capillary refill more than 3 seconds, urine output less than 1, lactate more than 3, base deficit more than 8, or difference in the core to peripheral temperature more than 3 degrees. And then come back to the biochemical parameters and echo parameters. So clinical criteria of a defined shock along with biochemical, like lactate base excess, and then comes the echo for definition. And this is the German network gestation. So you can see the range is 18 to 25. So some of these babies can be little hypotensive. So a 25 weeker may have a blood pressure up to even 21, 22, and that might be still in the normal range. So don't always stick to the mean equal to gestation, especially for the smaller babies less than 28 weeks. And preferably use NIBP for monitoring. And the one last thing, uh, yeah, I think I did not cover the so IVC eyeballing preload, but again, I think we'll try to cover that in the workshop. So IVC eyeballing can tell you the preload, and the afterload can be calculated with the systolic and diastolic blood pressure. So this is another good slide which I always talk about, and we can talk it in the workshop more detail. But basically, try to look at the diastolic systolic blood pressure separately, because there are different causes of low diastolic and low systolic pressure, and depending on what is dropped, the mean will drop. But basically, you will know that your SVR is dropped. So basically, whenever diastolic is dropping, probably your SVR is dropping because there is probably decrease in the afterload because of either sepsis or NEC, SIRS or PDA, or diastolic can also drop in the decreased preload. So hypovolemic shock also diastolic might drop. So you might have septic shock, hypovolemia, bleeding, etc. Your preload might drop. So diastolic drop can be because of decreased preload or decreased afterload. And systolic drop mainly because of the decreased contractility. So if you have a myocardial compromise, asphyxia, cardiomyopathy, your systolics will drop. Or if there is a too much SVR, so cold shock, and sometimes transition circulation, there is an increase afterload, or a polycythemic baby, there is increase afterload. So there the systolic drop. And in a lot of progressive disease, you might have a combined systolic diastolic drop. So this is another parameter which is not actually the echo parameters, but as somebody mentioned, icon device can actually calculate and tell you whether SVR is low or high based on the whether it's systolic or diastolic drop. So with this, I think I'll end. Uh, Try to focus on differential parameters, and no need of giving routine boluses. And yeah, uh, yeah, we can keep talking about the management part, but that's not the focus of this talk. So I'll stop here and happy to take one or two questions. Yeah, IVC collapsibility or distendability, contractility. See, there are different indices for IVC, and I can show you the slide. But many times in newborn, we train to eyeball. You may not get a very nice collapsibility index and contractility index as in pediatrics. So eyeballing, if the IVC is collapsed, then it's probably underfilled. If it's too congested or distended, then you are probably overfilled. But if you see a congested IVC, you will not. You have to see if there is no high frequency going on, or babies intrathoracic pressures are not very high. So all those parameters probably you'll have to look at. and then only you can comment about that. So, yeah, I mean, you basically can do an M-mode, or you can just look at the like this picture. So this is like a dilated IVC. So you have a congested little bit of dilated IVC, and normally what will happen? See this one also. So you will see a bit of a contractility of the IVC with respiration. It will move, but a dilated IVC, it will be very tight. You will not see a lot of movements. And then you can do Doppler also. You can do M mode also, and you can see the changes in the variation of the IVC in the systole and diastole. So that will tell you the preload. So always look at the IVC if it's congested or collapsed, and that can give you some picture of the preload. And the parameters like pressing on the liver and the CVP goes up, all again are more on pediatric. Generally, we don't have CVPs, but if you have a line where you can do CVP, that something can be a surrogate, but again, not very accurate in the newborn. Okay, anything else? I hope it was okay. I mean, we just gave lots of concept, more again hands-on when we meet. Okay, Rajesh sir, I think no more questions, so then we can stop.
Yeah. Thanks. It
Okay,
was a nice lecture. Thanks.
thank you very much. Okay,
Okay, okay, bye.
goodbye. Thank you, Dr. Mohit. Good night. Bye.
Bye.
Bye-bye.